My name is Chris Bowling. For those of you who don't know me, I'm actually a pediatrician in the Kentucky suburbs of Greater Cincinnati. I've actually been doing pediatric obesity work in my practice. We have a program in our own office I'm going to tell you a little bit about. Then I'm going to go through these really fast because I think it's important to kind of toss all this information up that you will then have in your syllabus. But I want to have some, it'll be posted online. All this will be posted online. So as I blast through a zillion codes, and I'm going to go fast because coding can be really boring, but we're going to go through this just to kind of throw out some ideas. The resources will all be available to you after the conference too. So, Barb, when you mentioned at lunch that you were looking for a sustainable thing, I really think coding and billing is the key to sustainability for doing an obesity program in your office. If you're going to launch into it, you have to be, I don't want to say creative, but you have to be very appropriate about coding and billing. So let's get started. We're going to talk about some different methods for making weight management services affordable, discuss the essential components of weight management and what you can do around coding and billing, and describe some current trends that are happening around the country. Actually, I think things are getting a lot better. Sandy Hassink, I don't know if I quite go as far as she says. She says, and I probably shouldn't speak for her, but I'm going to. Her comment to me once was, she said, saying that you can't be reimbursed for it is an excuse. We can do it. We can get reimbursed for it. And I said, Sandy, I'm not quite there yet, but it's getting better. I still think there are a lot of challenges. For those of us in the Southeast, it's still really a challenge. For those of you in the Northeast and other places, it's a little bit more, but try it in Texas and Alabama and Kentucky. It's tough. I don't have any financial thing to disclose in it, but I do want to thank Rick Tuck, who is an AAP coding specialist from Zanesville, close by me. Okay, I think there are a lot of encouraging signs. Charlie mentioned it, the HEDIS requirements from NCQA for nutrition and activity counseling, the Clinton Foundation recommendation that we fund 5 visits. I think these are all really encouraging signs, and they're making a difference in certain places. So I think times they are a-changin'. Think about obesity care as a pyramid where all of us are doing risk-only, large numbers of patients, the base of the pyramid going up, screening for high-risk kids, treatment for overweight kids, treatment for obese kids, treatment for severely obese kids, fewer and fewer kids as we go up the pyramid, higher and higher levels of intervention, things that you're going to be progressively less able to do in your office as you march up the pyramid. But we're going to talk about finding your spot on the pyramid where you feel comfortable. Your role is to do prevention for everybody. If we're primary care docs, primary care providers, our job is to do prevention for everybody within our practice, and I'd also say in our community. You want to do intervention that you can manage. There is not a thing wrong with saying, I cannot handle this patient who needs gastric bypass surgery. Don't worry about that. You have asthmatics we have asthmatics who we need specialist help for. We have cancer patients who we can't manage in our office. I would argue that kids who have severe morbid obesity with high levels of complications, don't worry about fixing everything. You can't physically do it. So I don't want it to sound like it's a cop-out, but you have to also know what your limitations are. This is a very young discipline, but part of knowing how to manage obesity is not only knowing your limitations, but also knowing how you plug those kids in. If you can't take care of them, what is your strategy for handling them? My heart goes out to practitioners in Eastern Kentucky. When I was at Children's in Cincinnati, one of my roles, and I still participate with it a little bit, is the bariatric surgery program. Loads and loads of our patients came from very rural areas in Eastern Kentucky and Eastern Tennessee. We were the referral area for them. I do not know how you could possibly deal with something like that far afield. But it's really a challenge, but those providers at least started to learn how to refer into us for those kinds of patients. But it's very different. It's lots of regional variation on who has what programs. Prevention, we all know what to do about prevention. We're going to skip right over this. We're here to find tools. I wanted to pop these up here again just so you kind of have these. There are some billing resources on some of these, and I'm going to show you a lot more. Why should we care about coding and billing? We want to have increased and appropriate payment for our services. We want to have decreased liability, be very blunt about it. And we also want to have improved communication and reporting, meaning that we can get to a point where we have improved, meaningful data and outcome results that we can report. We want to know what's working. And until we have accurate coding and billing, we're not going to know that. Part of the issue around that is, many of us, how many of you here are like, avoid using the diagnosis code of obesity at all costs? I know I've been in that category, where you're like, I can't code obesity, they won't cover it. So that's a bad position to be in. We need to get past that weirdness in coding. And I'm not saying we're there yet, and it's not our fault. That's what's kind of forced upon all of us as healthcare providers. But we have to figure out some way that we can report those things and code appropriately so we really know how many kids are being treated in offices for obesity. A quick other statement about prevention. What about billing for prevention? HEDIS mandates nutrition counseling. It's a very tricky area. If you were to do billing for prevention, I don't do it in my office, and I'll talk about the 25 modifier in a little bit, but if you were to do it, probably the best way to do it would be to do a 25 modifier on a visit if you were going to do obesity prevention. I think it's a really tricky area. I personally don't do it, and like I say, we'll talk more about the 25 modifier in a second or two. Loads of overweight and obesity codes, and these are the ones that I'm mentioning to you are ones that are really tough because there's this disincentive to put it on there. I had gotten to a point, I don't know if anybody else has encountered this, the minute you put obesity on it, for a while there, you put obesity on it, it negated every other code that you put on there. Like, so, hey, that's what we're gonna get. We're gonna leave it off because, I'm worried about these health complications. That's why I'm seeing this patient. Yes, they're obese, but I'm worried because they've got NAFLD or NASH or pre-diabetes kinds of syndromes. So we need to get rid of that disincentive. I think it's coming. It's not there in all states yet. But what codes am I talking about? 278, obesity unspecified. 278.01, morbid obesity. 278.02, overweight. So those are the ones that I'm talking about, the ones that we need to figure out a way to get rid of this disincentive for using them. We're missing out on important data. What's my Kickstart code? Anybody know what my Kickstart code means? What code do I use when I don't know what else is going on and I'm worried about this patient for obesity? I use 783.1, abnormal weight gain. You'll hear people say, oh, abnormal weight gain, that's not what we're talking about. We're not talking about behavioral obesity. What we're talking about is we're talking about thyroid disease and insulin problems. That's what I'm looking for. So I'm using 783.1 oftentimes for initial visits when I don't have a comorbidity yet. What I can use to get the labs drawn, I've had, knock on wood, no problems with using this, and I try to move away from it as quickly as possible because certain insurers will not like 783.1 used over an extended period of time. Anybody else have experience with using this?
We have. One of our coder specialists came to our clinic. We do a pediatric management program and strictly forbade us from using this. And under the, when she looked up in her code book, it says, you cannot use it if you're looking at obesity, if you don't have any other comorbidity. So she was a huge.
And I've heard that complaint many times. But and that's why my take is you're not using it to manage obesity. You're using it initially to rule things out, and then you're moving on. Anybody else had other issues with this?
Weight management program and we use it on basically all of our patients that don't have a comorbidity, and it's 24 on
Yep. And there is a little variation. You will hear coders who will have a stroke over it. Yeah, but you can use it. Like I say, the key is get in, get out. Okay?
Doing the labs.
Yes.
And if you're not going to do the labs, you can't use it.
Correct.
After your labs come back over, you're still using it though.
But they're still using it, and you know what? And when I'm really pressed, like I'm going like, I can't find anything else, I'll sometimes still use it. But I try to get away from it.
Our med sheets
Yeah, yeah. It's like, this is like crack. Use it, get off of it, okay? Don't get hooked.
Although we've been using obesity from May to not same thing.
It is confusing. So pre or first visit labs, what do? I was waiting to hear what Dr. Hassink was going to say about this. Here's what I do. You'll hear some people say that's not what you should do. There's some other things you should do. Here's what I use. I obtain my labs as fasting labs. I get a TSH because our endocrinologist told me to get a TSH. And then I presented this at Grand Rounds one time, and I had one of the endocrinologists say, "Why are you getting a TSH?" "Because your colleagues told me to get a TSH." I'm getting a TSH, and I'll tell you why in just a second. I don't get full LFTs. I usually just get a GGT, an ALT, and an AST. That's what I've been trained to use to screen for NAFLD and NASH. I do my carbohydrate group, which is hemoglobin A1C, glucose, and insulin. Again, you'll hear the people say, you should not track insulin for obesity. You should be tracking weight and health wellness. Absolutely, I totally agree. But if you're trying to motivate a family, an isolated, you're not using it to track them, you're using it to demonstrate presence and risk of comorbidities. I get a fasting insulin, and I also get a lipid panel. I do these all fasting. With the first labs, I do the TSH just to get it off the table, because you will forever get caught, in my experience, in the he's got a gland problem.
So what do you do when it's 5.2?
If it's elevated,
Normal's up to 4.9.
I do a free T4.
Huh?
I do a free T4.
Normal.
Then they're normal.
You're not sending them to the end.
I'm not. They're normal. But I use TSH as a screen. I had one person say, you hear all sorts of folklore out there too. I said, well, you know, a TSH only costs $27. No, it doesn't. It costs $125 at our lab. But it's not, you know, it's not $1,000, but it does cost, and I do it one time, and I never do it again, if it's normal. If they have signs of NAFLD or NASH, it's the same diagnosis code. It's 571.8. You can use this diagnosis code if you get a GGT over 24, an ALT or an AST over, why did I put 24 in there? Sorry, that's a typo, over 40. If only the AST is elevated, it's more likely a viral pattern. But just so you know, if you get these over 40, you can classically say you have some liver irritation. Okay? Carbohydrate metabolism. Hyperinsulinemia is what I use at 277.7, and hyperglycemia. I'm defining these at hemoglobins of greater than or equal, hemoglobin A1C of greater than or equal to 5.7, a fasting glucose of over 90, or an insulin greater than 10 to 15 based on your lab. I use 15. It is going to be in the syllabus. Yes, it is. And if by some chance it's not, here's my email, and I'll email it to you. Okay, so basically, and you know what I'm doing with the insulin? I'm using this for coding purposes, but I'm really, you know, this is also an important. That's an insulin of 18 is abnormal in a child. You know, 13 probably abnormal. 18, 20, that's abnormal. Those numbers are powerful statements, I think, to families that your carbohydrate metabolism is changing.
So if we don't get this fasting,
It's meaningless.
but it's meaningless to you and me. It's not meaningless to the coding. Because we could then basically say, but again, I have trouble getting fasting tests.
Yeah.
And so I'm getting my lipid panel, it's not fasting, which came out we could do, my hemoglobin A1C, which we can do.
Mm-hmm.
So now I'm going to have an insulin level that's 27, always, minimal though.
Yeah.
So the coding. has nothing to
They
do
might
with
not. I think.
fasting or not fasting.
Yeah, they might not, but although that's normal. I mean, if an insulin level.
I know it. You and I know 5.2.
La 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 la.
That's like shortness of breath.
Right.
Exactly.
Again, what you're doing to
So-
get this
So
marked out.
again, you're not going to have, like, this is not going to come out of the American College of Endocrinology right now, but what I will tell you that the endocrinologist that I work with, actually this is Nancy Crimmins at Cincinnati Children's, her parameters for me is if you have a fasting insulin, this is just an aside, fasting insulin greater than 30, greater than 25 with a first degree family relative, fasting glucose over 100, and she actually does, this I think is a little aggressive, is a hemoglobin A1C of greater than 5.7 is considered to be abnormal and warrants an OGTT. Seems high, seems like pretty tight parameters to me. On the lipid panel, I tend to just use one. I tend to use, you can get fancy, you can do mixed, combined, pure, all these other things. I tend to use hyperlipidemia NOS 272.4. And I'll use this if you get a total fasting cholesterol of greater than 170, an HDL of less than 40 in boys, less than 50 in girls, over 130, and a triglyceride of greater than 150. Okay? That's what I use. Other favorites from history, elevated blood pressure, which is a little easier to diagnose than hypertension. You know, that hypertension requires the multiple repeated ones, but I'll use elevated blood pressure at 796.2. In the young, as Sandy was mentioning, one of the few comorbidities that preschoolers with severe obesity will get is sleep apnea. I use 327.23 for that. Acquired acanthosis nigricans, 701.2. Binge eating. A lot of kids are, will binge at night. Other disorders, unspecified disorders of eating, 307.59. Or some of the other ones I use. Barb.
If you're trying to avoid coding for obesity, can you just keep coding for acanthosis nigricans?
Yeah. Yep. Yep.
Well, no, I'm trying to see, so you've seen this kid the first time, you did your abnormal thing, he comes back, you review his lab test, you put down all these diagnoses, now what?
You can
I'm waiting.
you can continue to treat them. You can treat them. You use these diagnosis codes to treat them. So, others to consider that are weight-related ones that you can certainly use for weight-related things. And I don't have all the numbers listed up here for you, but back pain, Blount's disease, skiffy, leg calf perthes, shortness of breath, wheezing, PCOS, abdominal pain, headache. You know, what is it that's causing problems for them? That's why they're there. That's why you're seeing them. Okay? So the comorbidities are critical. V codes, who knows? You know, I mean, I think they're useful. I don't know what they mean at this point. We can't use them to bill anything. So I kind of toss them up there, but I really have not used them. I think there might be some utility with them when we're able to, for tracking. Yeah, for tracking.
I like when I can change it to that. Yeah, 54 to 15 even.
Yeah, yeah, yeah. Okay. Any other thoughts before we move on from V codes?
Yeah, for regular codes too, we use just a sleep disorder, not otherwise specified.
Yes,
They
yes,
haven't had a sleep disorder.
yes.
Well, the problem is we use billing databases for clinical research.
Exactly.
Tracking these, and we're not going to be able to pull the population.
That's absolutely right.
Unfortunately, these are not devised as research tools.
Correct. Correct. So, and that's the crux that we need to get past right now. Where there's this distance, that's the disincentive that I was talking about, and we need to get past that. And I think we're on the cusp. I think we're going to get there.
So if I want my, I don't know if that's what you're touching on, but, so if I'm gonna bring this kid back once a month, 12 times a year,
Mm-hmm.
you build like that, 12 times a year, and you haven't had any problems.
I've not.
We do once a week for the first 2 months, and then every 2 weeks for 6 visits, and then once a month for another 6
And
visits.
private insurance is paying?
Yep.
Insurance, if I have these comorbidities,
Yep.
they're paying. Unfortunately, they have co-pays and deductibles for those private insurers, but for those part, there's not.
And we're tracking it like a hawk. We are seeing, this is a great question, and we're going to get to we see in our practice, they're either seen by me, my nurse practitioner, or my PA. So it's one of the three of us. We don't have a dietitian in there with us because those are a little different. We'll kind of go into that. Resources, your 5210 flip chart has some great diagnosis codes in there. The ICD-9 coding tool from the AAP and Bright Futures is also helpful. Coding 101, this gets right to the question here. Physician selects the diagnosis and the billing codes, and it's confirmed by your office team. These are just general principles. Use separate codes for services provided. Document what you do in order to support your code. Obviously, it's because it's good for care and compliance, and it's important for when we're billing based on time, and we're going to talk about that. These are from Rick, my colleague in Zanesville. This is what we do. You know, most of us do the 99213s, a preponderance of 99213s, a few focused, very few detailed, and even fewer comprehensives. So these are your 99211, 2, 3, 1, 2, 3, 4, and 5. Okay?
We just got audited at our clinic,
Yep.
and they all told us up it.
Exactly.
Oh, okay.
And this is, when you really look at the time that we spend, this is where we should be. We should be in close to equal numbers of 3s and 4s. Okay?
When you say we, is this data from Ohio or is this
Nationally.
nationally?
Okay? We should really be in, for general practice, not weight management, general practice, we should be more in an equal zone with 3s and 4s. We need to be better at upcoding for what we're doing, and you're going to see why in just a second. For weight management, I would make the case, and Rick makes the case, that we should probably have 35% here, 35% here, and a significant number of comprehensives, especially for initial visits, and especially for when we do a lot of other things with them, when we're taking exhaustive family histories, and we're doing a lot of interpretation when we're interpreting all these lab values. More coding 101, inquire, like you mentioned, like who's watching this? Are you getting reimbursed? Watch the EOBs, and appeal when necessary. It's going to take working with one of your billers in your clinic setting to really be watching this stuff. Consider a computerized super bill. Consider your obesity codes just so it's easier to track is the only reason I say that. Okay, 7 components of these E&M codes, of these evaluation and management codes. History, examination, medical decision making, we all know this. Trust me, when you're doing an initial one, you have way more components on history because you're talking about a hugely long review of systems. If you're asking about sleep apnea and leg pain and back pain, shortness of breath, you're asking multiple organ systems, you're covering it, especially on an initial. Exam, same story. You're doing neurologic, you're doing a skin exam, you're doing abdominal exam, you're doing a GU exam, you're doing everything because you're, by necessity, this is a patient with obesity, you're looking at endocrine system, you're looking at everything. Medical decision making, you're interpreting labs, you're doing this, you're coming up with a comprehensive plan. You are really getting those components with that first visit. Counseling obviously makes a difference, coordination of care is involved, nature presenting problem, and I'd really stress time. Let's talk about that. Time trumps all the other ones. Everybody remembers that? That, you know, that the amount of time you spend doesn't matter what you do on all the other things. If you spend the time, you are at the level, okay? It's an explicit factor to assist in selecting the most appropriate E&M code. When counseling and or coordination of care are more than 50% of the face-to-face encounter, then time is the controlling factor, okay? So 50% of the face-to-face encounter, if it's in time, it moves up. So what does that mean? You got to document it, but look at these numbers. I mean, come on, you're talking with somebody with an obesity follow-up visit. If you're me, I'm in there for 15 to 20 minutes easily, and usually a lot more than that. So that's the time-based coding. Now we're talking about 50%. I mean, technically, it's 13 minutes of counseling, you're a 99214. If 20 minutes of counseling, it's a 99215. Now, I'll be very honest. I use my 99215s on my initial visit. I have not been using them on my follow-up visits. I probably could. Because, you know, if you're spending 20 minutes of counseling on a follow-up visit, you're probably there.
Is there any data that shows other programs have used that 5 safely?
I've used it safely. So, you know, yep, I have. Have not gotten dinged. Now, we have a lot of people, like, I have to admit, some of my hesitation to do this is, you know, some people have different, you know, they have high deductible stuff, et cetera, et cetera. So I'm a chicken. I tend to go to my 99214, but clearly your 99214s, you're hitting those on your follow-up visits. And really on my initial visits, I just kind of swallow hard and do 99215s, and I probably just need to get more guts about it and just do it more regularly. Okay, so now again, I've rounded these up in 5-minute increments, and that's what most people will say. I mean, you could technically say 13 minutes, but for those of you who take the pre-test and post-test, the answer is 13 minutes. But the 15 and 20 minutes, you know, if you're thinking in 5-minute increments, that's where it is, okay? Preventive medicine services, I'm going to go.
My problem with that's going to be is I looked at my schedule. They have me scheduled for like, they got my schedule. It's like 15-minute things.
Oh, you can't do those
or
for
double
weight
books
management.
and all that other stuff. It's just,
Can't do it. But you know what? We build it into our office setting. So for me, when I see a patient, they know I'm going to up bill, so I get extra time for it.
I'm never on time, my schedule says what it says, but I'm routinely making sure you
but
are.
I mean, oh,
Yeah, so whatever your schedule says, that's not
But
what.
that's not what the auditors or the lawyers are gonna come and say. They'll say, could you pull Dr. Feinstein's schedule? Oh, we had a patient at 9:15, 9:30, and then they're gonna say, oh, Dr. Feinstein, all it says here is you saw 4 patients.
But you need to document how much time you
Right,
saw in
for
the
each
chart.
one. I
Yep.
understand that.
And so these are the critical numbers that you need to have documented in there, which I do with those visits.
So that would override that concern. If a lawyer
I'm just gonna need to
you
put it on my
documented your
form as
time,
check.
that just
Correct.
shows that with the patient.
But I think
I mean, we can pull the patients in.
we don't
Did she
have
really
that.
have the time?
Right. Now, I'm going to blast through a couple of other possibilities. Again, these are all in your syllabus, just for you to kind of think about and experiment. These are not things that I use very often. Preventive medicine, kinds of things, we talked about that a little bit. The 25 modifier, here's where I'm going to talk about that. If you have a significant problem like obesity found at it, you could do an appropriate E&M visit and use the 25 modifier. People familiar with the 25 modifier? So you could, 25 modifier is if you have an additional illness tacked on, you have like your well visit, plus you modify it with a 25 modifier, you can put an EM visit along with it. It can still be based on time, yada yada, can still use the preventive codes. Parents don't respond well to surprises. My statement about that is, I did that for a little while and parents are like, well, wasn't that part of the checkup? I just, I bring them back. I mean, you're talking about something that's really important to them. I bring them back. It's worth it, and you're really spending time on it. It's not an add-on kind of thing. I have given up doing 25 modifiers on well visits. I just think parents, I don't know. Our whole practice, we did it for a while and we're like, parents are just getting too upset with it. And it's kind of confusing because, when is it significant and what's one person's significant and another person's not significant? Anyway, we went away from it. Yeah, exactly. So we just avoided it. We just kind of stopped doing it. You can use the health and behavior assessment and intervention codes. These are to be used only by non-physicians. I just want to alert people that these things are out there. These are codes 96150 through 96155. Again, these are ones that are used by, you can't use them on the same day that a doctor sees them, but these potentially could be used by health educators, by dietitians, office nurses, etc. Sure. This one? I'm sorry.
You just hit it, that one.
That one.
Behavior codes you can.
Okay.
So you can do the family, and that's more than just that.
Correct.
As a group or the family?
Yeah, you could. I'm sorry. So
So a
So
group visit and then the family patient present would be different.
correct. Okay.
So you could bill them both on the same day?
You cannot bill them the same. Oh, I'm sorry. Psychiatric and these services cannot be. My understanding is you can't do this on the same day. Have you been able to?
We did. Patients see Diana and us on the same day. We use the health and behavior code.
Oh, okay. I stand corrected. And she uses those codes? Thank you very much. My understanding is that you cannot use them. Good. Good news.
Because we have to lump them all.
Yeah, we had to lump them. In Ohio, we had to lump them.
Right. But I don't think you can do a group and a physician visit the same.
But we can bill.
Well, anyway, there may be some state variation, I guess, is the statement. Okay. Education and training for patient self-management. Again, these are used by sometimes our diabetic nurse educators. Usually you use a standardized curriculum when you're using these. This would be conducive to certain things that we do in weight management. These typically are 30 minutes in length. They involve face-to-face, and they're based on the number of patients that you see. So there are different codes that would be a possibility also. Health risk assessments. Again, you need to use a health risk assessment instrument, so it usually is a standardized tool. Consultation codes. For those of you who see patients, most all of my patients are patients that are in my practice. patients that are referred from other places, if you are in a small town and you take referrals from other docs, I would strongly encourage you to use consultation codes because payment tends to be 25 to 40% higher than the corresponding E&M codes.
Yeah, they did. I think you can use it as a new patient code, but not a consultation code.
Right. They got rid of,
We
in a lot of
use it-
states.
We use it for a consultation as long as they don't have main care.
Private's
Oh.
If they have main care, you
Private's
cannot
still
bill
paying,
them.
Medicare's getting rid of it.
Right, Medicare, Medicaid got rid of
Medicare got rid of it,
consultation, but
depends on the
private
state.
is still.
But I think if you use a new patient initial, it's actually a higher.
Not, yeah, so yeah, so it may be different in Maine, not, these are what we use in Ohio and Kentucky and Indiana. Okay? Yep. And if you are taking referrals, I would encourage you to use these. Because if you're taking from your own practice, you can't. It's very, very tricky. The issue is, it requires communication back. It's, again, just very tricky from your own practice. Are you seeing your own patient? Or are you seeing one of your partner's patients? And if your name shows up in their chart, you can't do it. And it's just very confusing. But if you are taking, if you're at a referral center, that's one way this is what we always used is at the referral center. The R's of consultations, remember, medically necessary, requested by another physician, report back, and that they return back to their requesting physician, that you do not acquire them as a patient. Office consultation kind of goes in these time increments as well. Prolonged services, I have never used these, but they're a code service defined by prolonged service by site, with or without direct patient contact, and it's in increments of 30 minutes or more. I just toss these in so you can kind of take a look at them. You can use them if you want to. I've never used them.
You don't think it high reimbursement?
Yeah, I don't. I've not used them. Not used them.
I just joined the practice, and referral source for eating disorders. We spend 2.5 hours.
Yeah. Yeah, it might be worth investigating. Absolutely. Non-face-to-face physician services are things like telephone calls, reviewing records, completing forms. Those sometimes will come under case management services, depending on who does it with or without direct contact. These are the codes 99366 to 99368. The old ones have been deleted, 61 and 62. Medical nutrition therapy codes are ones that are often used by our dietitians, frequently more used by our Medicaid programs than other places. I know a lot of times our private insurance companies will not cover these medical nutrition therapy codes. Again, they must be provided by a registered dietitian where I practice. May require we had to always do the 25 modifier if it was done on the same day. This is the code that we used with our dietitians. Was we would have the physician code and then 25 modify a medical nutrition therapy code. So we couldn't use the other ones, but we used these. And again, just a statement like what we do in our office, all of our stuff is provided by physicians, PAs, and advanced practice nurses. So we just use E&M codes. HCPCS codes, education and counseling, things like these are some appropriate for some folks if you have these in your office. Oops. Procedures. If you do things like body composition, there is not a code currently for body composition, although sometimes it will go under, we'll find other ones we used for BIA. I can't remember what we used for BIA. Yeah, there is one. Yeah. Yeah, it's right, and we would actually bundle it in because we used more time to discuss it. It's how we did it. So there are ways around that, like if you do a body composition analysis, like with calipers or with BIA, you could upcharge based on the amount of time that you used to discuss it. Calorimetry, glucose monitoring have their own codes that are a possibility. The AAP fact sheet is very helpful. It's on the practice at AAP.org at the Practice Management Online site, or you can also go to the AAP Coding Hotline at AAP.org. I'm going to tell you our approach very quickly based on these kind of codes. What we do, we have a group, as I mentioned to you, we have 3 offices. We have 14 docs, 3 nurse practitioners, and 2 PAs. Myself, one of our nurse practitioners, and one of our PAs are very interested in this topic, so we have our own program called Basic Training, and here's how we would do it. Our practice identifies patients over the 95th percentile. Our program, we think, is fairly scalable and easy to tailor, and it's built into our regular day in the office. We use MI, motivational interviewing, as our counseling framework. We all have done some training in that. And I'm actually a trainer in that. So how do we do it in a busy practice? We code for comorbidities. We avoid codes for counseling. We use the time component. We don't do it in a single visit. We do ongoing visits. And we use MDs, NPs, and PAs to do our billing. When we got started, we have our provider.
So you say, you go back, you just said that you do the nutrition counseling.
No, we do E&M codes.
No, but it says to have more success in RVs getting reimbursed. So when the kids come to you and you're going to go over, you get a food diary. You get food diaries. I mean, you'll do that. I mean, you'll do the 5210. You'll sit down and
We'll do portion size.
portion size. So you're not involving the RD.
Nope. And RDs are a wonderful resource. Our RDs are a wonderful resource, but we're not using, we're doing basic nutrition.
I concur.
We do have our providers who are involved. You may have, and these are different places where you may have different things. Counselors, a billing specialist is important, I think, for everybody. Knowing your community resources is very important. So we have, this is sort of our basics that we have that I think you need to have. The initial visit, I mentioned to you what we do. We plan on it being a 30-minute visit. On the initial visit, we do an exhaustive family history and review of systems, complete physical exam, and we start our MI-based counseling, and we plan on billing at a 99215. Subsequent visits, we assess readiness. We use ongoing motivational interviewing based counseling. We talk about our first pass through being a 6-month induction period, but we continue on for as long as the families want to continue on. Visits roughly go about 1 to 4 weeks. When kids are at the end of their visit and they say, when do you want to, I say, when do you want to come back? They always look and go, I don't know. We usually say somewhere between 2 and 4 weeks, and that's usually what they pick. We have them pick a tailored exercise program that they want to do. We have several around in our community. I find with exercise programs, if you try to have one in your office on a Wednesday night or here or there, it's hard. They don't show up. They tend to have some sort of conflict. You also need to know when to refer. I would just say, just aside from the pyramid, you can also think of obesity care as a spectrum, everywhere from prevention, which occurs out in the environment in schools, to what happens in your office and with community interventions, to what happens at the hospital, and what you do for those treatment failures. So you need to know about your local referral center, wherever that may be. What kind of things do they provide? We have a referral center at UK Medical Center in Lexington that only diagnoses. It's important to know they don't do any therapy. So how does your center handle comorbidities like type 2 diabetes? What subspecialties should you go to? You just need to know the basics. And what studies are your patients able to access at these places? A lot of times, that's a great resource. We have a lot of preschool programs that are happening at Children's for us. We have a lot of adolescent programs. So those are great resources to kind of get kids plugged into different research protocols there. And then also, I think it's useful to know your various bariatric surgery options, because some of your kids, the ones that will seek help with you, are ones who are beyond medical therapy. So I just toss that in. What's their philosophy? When do they want to see them? Knowing that for your referral center is important. Where would you guys in Maine send a patient for bariatric surgery? So Boston?
And so for Portland, we can refer a patient to start the counseling process if they're, I think it's within 4 months of their 18th birthday, but they won't do it younger than that.
Yeah, we're in Cincinnati. We're a referral, so we have kids coming in from all over the place because there are just not that many centers.